Tuataki me mihi ki te rungarawa nana nei ngā mea katoa, tuarua me mihi ki te iwi. Tēnā koutou, tēnā rā tātou katoa. Can you hear me at the back? Excellent. Greetings and welcome everybody. Welcome to this Public Health Friday seminar. We have sent out invitations wide and far to colleagues in the Ministry of Health and to midwifery colleagues. So if we have visitors from and colleagues and friends, welcome to all of you. Welcome as well to the media colleagues who are here today. And also, welcome, I think, to those who are joining us by web conference. We're having a few technical issues right now, but if you are there and hearing us on the web conference, welcome to you. And if, perchance, we don't have the video sorted by the time I finish talking, then we will go to audio web conference only, but we will be welcoming in the participation of our web attendees, and they will be able to post questions, I believe. Is that correct? Good, thank you. Look, we do have one particular web attendee, George Salmond, who's joining us today, and I'd like to welcome George in particularly. George was the Director General of Health during that period of time, during the early 1990s, when the maternity reforms were introduced. And George has an abiding interest in those issues. Very sadly, George is unwell and not able to join us today, but I would like to acknowledge George's warmth, compassion, abiding interest in these and many other issues which affect so many people, and his incredibly committed hard work over many, many years. So thank you, George, for joining us, and I do hope you can hear this. My name is Peter Crampton. I'm a Professor of Public Health in Kohatu, the Centre for Holder Māori, based in Dunedin. Part of my research interest over many, many years has been health systems. So this presentation is of great interest to me from a health systems point of view, the sort of research that drives constant self-examination, self-critique and improvement within health systems. As well as that, during the time that this research was conducted and disseminated, I was in the role of Pro Vice Chancellor of the Division of Health Sciences. So I had an additional role at that stage of supporting the researchers in their dissemination of this research. Noting again that the intention of this research is health systems improvement. So it's now my pleasure to introduce our two presenters today. They are Ellie Wernham, who is a former midwife and a former MPH student, and I believe this research came out of your master's thesis, and is now a medical student at the University of Auckland. So thank you, Ellie. And Di Sarfati, who is a Professor of Public Health and an epidemiologist based here in Wellington. They will be speaking for 45 minutes and not a second more. And then we'll have a little bit of time at the end, 15 minutes or so for questions and some discussion. And at that point, we will welcome in the questions from the web attendees. Their talk's divided into three parts. Policy changes first, followed by a talk about the study itself, and then the aftermath to the study. So once again, welcome everybody. Thank you for being here. And I'll hand over to our presenters. Thank you very much.
Thank you, Peter. Kia ora koutou, welcome. I'm Ellie Wernham, and as Peter said, this is Professor Diana Sarfati. Together with others, we authored this study, which was published in PLOS Medicine in 2016, a comparison of midwife-led and medical-led models of care and their relationship to adverse fetal and neonatal outcomes. The journey of our research has been an interesting one, which is what we're here to share with you today. So why did we do this study? Here I am following the birth of my son, who's now much older. And before having him, I was a midwife. I trained in Dunedin in the mid-2000s under the direct entry midwifery program. I really loved being a midwife and found it a huge privilege to be part of a woman's journey to motherhood. But I was aware as a new graduate midwife of the maternity debate, which was present then as it is now. There were frequent media reports of maternity system failings. And as a young midwife, this really affected how I felt about my profession. And I remember feeling then that the college and representation of my profession had a lack of evidence to draw upon when responding to these criticisms in the media. Evidence-based philosophy was part of my midwifery training, and when I went on to do a Master's in Public Health, I really learnt more about what constitutes an evidence base. So when I was choosing a topic for my Master's thesis, it was a natural progression for me to want to address the paucity of evidence that looks into safety-related outcomes in the maternity care system in New Zealand. So how did we get the system we've got today? I'm just going to spend the next few slides going over how New Zealand became one of only 2 countries internationally to adopt a midwife-led model of maternity care. So before 1990, maternity care was medically led and autonomous midwifery was illegal. The 1980s saw resistance to this model with consumers of midwifery services and midwives rallying that the birth experience of the time was alienating for women who were subject to unnecessary interventions and had very little choice in their childbirth experience and control. So midwifery groups lobbied the government then to change legislation that would allow for midwifery autonomy and address these concerns. There are a number of factors at the time which were supportive of the plight of these midwifery groups. So firstly, the 1980s saw huge budget blowouts, and there was a real focus on cost saving. We just had the Cartwright inquiry in 1988, so this created an environment which was conducive with patient rights, feminism, and a reduction in male dominance over healthcare. But perhaps one of the most important factors was the Minister for Health at the time, who was Helen Clark. Helen Clark was local MP to Joan Donnelly, who was one of the forebearers of modern midwifery in New Zealand. So she had a long-standing relationship with midwives and was really supportive of their plight. And her role as Minister of Health played a significant role in the passing of legislation which has created the foundation of the maternity system as we know it today. So the campaign of the midwives was officially brought to the political table in early 1989 when Helen Clark wrote on an interdepartmental memo, "Please provide me with information about the midwives' campaign for autonomy. I'm supportive of it and would like to see how it can be progressed. I would expect a report on this and the proposed review of the Act by the 19th of May. So the Department of Health went to work and created this report, which in general was supportive of the intent of midwifery autonomy, but they instead supported that a degree of interdependence and collaboration remained between doctors and midwives. The Department of Health were not supportive of direct entry midwifery education. Instead, they suggested that it made sense that midwives remained nurse trained, and this best met the demography of the New Zealand's demography and best met safer standards. The department wanted this policy to be reviewed with an upcoming review of the Nurses Act later that year. Helen Clark, however, was more focused on an expedited approach, and she wrote again on another memo, for there to be any hope of passing this legislation in this 3-year term, the review will need to be speeded up considerably. Drafting next year means no legislation in this 3-year term. I would prefer a bill for introduction pre-Christmas. At the very least, drafting instructions would need to be completed pre-Christmas for a bill to be introduced early next year. Please proceed rapidly. So the upcoming election meant that she really, in order for this policy to come into place, it really needed to be speeded up. So later that year, the bill was introduced to Parliament. In its original iteration, this included 2 simple amendments which basically added the words "or registered midwife" after medical practitioner to the section of the Nurses Act which dealt with the practitioner who was responsible for maternity care. This bill was sent to the Social Services Select Committee, whose job it was to seek stakeholder and public submissions, and they did this and received 99 submissions in total. The majority of these submissions were from consumers of the maternity system with a strong home birth representation. And common themes in these submissions were that midwifery autonomy would increase women's choice, provide for continuity of care, that midwives were the appropriate providers for normal birth, and that it would decrease maternity expenditure. There are a number of organisations which voiced concerns about the bill, and these included the New Zealand Medical Association, 2 area health boards, and the National Council for Women. Concerns that these organisations raised focused on the level of midwives' education, the safety relating to absolute autonomy, and the mechanisms of review of midwifery practice. These organisations instead were more in line with the Department of Health recommendations in that they supported an integrative team-based approach where doctors, midwives and nurses worked alongside. The Social Services Select Committee took their concerns back to the midwifery organisations to get their views on their concerns. And through this process, they decided that the concerns weren't valid and that no amendments were required to the bill in this original iteration. Concerns that weren't so easy for the Social Services Committee to ignore, however, were ones raised by the midwifery groups, whereby the legislation still prevented midwives from practicing with true autonomy. So they sought changes that would allow midwives access to hospitals, to be able to prescribe medications, order diagnostic tests, and receive fair remuneration. So in order for these changes to be made, there had to be changes to legislation which covered over 27 amendments, which included 5 different acts and 5 different regulations. Opposition members of Parliament felt that the extent of these changes required further public consultation and stakeholder consultation. This was, however, seen by the government as a delaying tactic, and instead they proposed that these changes be made under supplementary order papers, which are not subject to the same level of consultation. So this is what occurred, and in August of 1990, the original iteration of the bill was presented to Parliament. So this included the 27 amendments in the first supplementary order paper, but it also included a second SOP. This one allowed for direct entry midwifery education. This SOP was not subject to any public consultation at all. And the bill in this form was passed into legislation formally on the 21st of August 1990. So there was extensive coverage of the passing of the bill, and with much debate between stakeholders. So you can see some of the media coverage here. I'll read out a few comments. The bill has caused much controversy and debate between nurses and the Medical Association, which believes midwifery training in New Zealand offers insufficient clinical experience for safe, independent practice. And from the chair of the New Zealand Medical Association at the time, New Zealand doctors working in the field of obstetrics have to meet tough requirements for review and recertification. No such requirements are made of the midwife, yet she'll be able to cope and may be encouraged to cope alone because it's her right to be autonomous. Helen Clark was quoted at the New Zealand College of Midwives National Conference in Dunedin after successive passing of the bill, saying midwifery had to battle for recognition, not only because it offers a different philosophy and perspective on one part of our health service and delivery, but also because as a female-dominated profession, it suffers from the inequitable treatment common to other such occupations throughout the workforce. Karen Gilliland, who is the CEO of the College of Midwives, quoted, "We always thought that it would come because it seems so right to give women this sort of choice, but it needed a woman minister to recognise the issue and deliver the legislation." So this created the maternity system as we know it today. It took some time for the system to work as it was intended, with initial budget blowouts because multiple practitioners were claiming for the same woman. This led to the government engaging with a consulting company, Coopers and Lybrand, who came up with the lead maternity carer concept. So this is whereby one practitioner holds overall responsibility and budget for the woman. And this is the system as we know it today. So today 4 out of 5 women have a midwife as their lead maternity carer, and midwives have full professional autonomy and the other aspects that they fought for. Supporters of our system suggest it's a model to be copied internationally, but there's been frequent questions since its inception around its safety. So how's our maternity system doing? The first means to assess the success of our system is in comparing our outcomes with other countries. It's really difficult to do this because of different ways that countries ascertain their cases and define their outcomes. But the Perinatal Maternal Mortality Review Committee are consistent in their reports, suggesting that we've got comparable outcomes to the United Kingdom and Australia. Another method of assessing the safety of our system is looking at perinatal mortality over time. So we can see here from the 1980s that perinatal mortality was steadily declining until around 1996, when the perinatal mortality rate has levelled out. So this is around the time that the LMC concept was introduced and the system started working as it is today. Now we can't definitively say that the change in policy is causative of the change in the levelling out of the perinatal mortality rate, but it's definitely interesting that it's occurred at exactly the same time. But it is important to consider that maternity outcomes are influenced by factors that are exogenous to maternity systems, such as better overall health. So descriptive studies of maternity are not sufficient. And and not sufficient when looking at the safety of our maternity system. So what's really important is New Zealand-based evidence when looking at our maternity care system. Why? There is a body of international evidence looking at the safety of midwife-led care. The most frequently cited review is the Cochrane Review, Midwife-Led Continuity Models versus Other Models of Care for Childbearing Women. But there's major reasons why this review doesn't provide evidence for the safety of New Zealand's system. So firstly, the studies that were included in the Cochrane Review, the intervention and comparison groups are very different to how New Zealand's maternity system is made up. The majority of the studies that were included in the review included midwives who worked in close collaboration with GPs. So the intervention group was midwife-led care, and in that midwife-led care group, all of the studies had routine medical input, and that's just not the case in New Zealand. Midwives in the intervention group were nurse trained first. New Zealand, it's direct entry. But also the comparison group had very poor continuity of care. So less than 20% of women in these groups knew the person who delivered their baby in most of the studies. So what the studies were looking at was a really well-organised midwife-led model, and comparing that with standard care, which was most often midwife-led as well, but it was much midwife-led as well, but it was much more poorly organised and standard in the standard care model. Another factor with this review is that none of the studies individually were powered to look at rare morbidity or mortality outcomes, and the 2016 iteration of the Cochrane Review included just under 18,000 deliveries. So even combined, that's not enough power to look at mortality outcomes. So in summary, the Cochrane Review does provide important information on potentially how to run a well-designed midwife-led system, and it indicates the central importance of midwives, but it's not sufficient to understand if midwife-led care is safe in New Zealand. So onto our study. From the outset, our research team consisted of 2 midwives, myself and another research midwife. We had a maternal fetal medicine specialist, an epidemiologist and Professor Sarfati, and 2 biostatisticians. We went through an extensive consultation process in the design stage of the study, and that was through midwifery representatives from a variety of DHBs, obstetrics and gynecology, and several epidemiologists, which I'll go through a bit more carefully. From the beginning, we were really careful with our data management, which included not linking any outcomes with other data until all analytical decisions had been made, and this is a way of avoiding bias. And I just want to point out that this process took several years, so the design phase was at least 2 or 3 years, with a back and forth consultation with various people. So this is the result. Going over the methods of our study. So we were population-based retrospective cohort design. We looked at 5 years worth of birthing data. This was the greatest amount of time where all data were available. So in total, we included just under 250,000 low-risk pregnancies. The exposures that we looked at were LMC at first registration. We're interested in first registration because the package of care that a woman receives throughout her pregnancy and intrapartum period has many ways in which it has the potential to impact on outcomes. And this is also the same model that's used in the randomised controlled trials included in the Cochrane review. So our groups were midwife or medically led. Medically led included GPs or obstetricians. So the outcomes were included were a range of morbidity outcomes related to adverse events surrounding the delivery and mortality outcomes. And then we also measured a number of different maternal characteristics. So one aspect of the methods that we're really aware required thorough consideration was in how we dealt with confounding. For the non-epidemiologists in the room, a confound is something that can bias your results when you're reporting on a relationship between your exposure and your outcome of interest. So in our case, model of maternity care and, for example, perinatal mortality. For something to be a confounder, it has to be related to the exposure, so model of care, for example, smoking is more prevalent in midwife-led care, and has to be related to the outcome, so smoking is a known risk factor for perinatal mortality. So we have more smokers in the midwife-led group, and these smokers are at greater risk of perinatal mortality. Without adjusting for smoking, reporting on results saying that midwife-led care is associated with perinatal mortality would be biased as the results confounded by smoking. So robust research really needs to deal with confounding carefully. And the ways that we did this through multiple mechanisms. Firstly, we used logistic regression modelling, which is where we included all of the different characteristics that I listed on the previous slide, included those in our statistical models, which adjusted for differential presence of these characteristics between groups. We used restrictions, so we only included low-risk births in our cohort where you'd expect a normal outcome. We did a number of sensitivity analyses, adjusting for rurality and high-risk pregnancies. We did exclusions and rerun our analyses. But perhaps the most effective and important way that we dealt with confounding was through the use of a negative control outcome, which I'll go through a bit more carefully. So sorry for the graph. The way a negative control works, just for the, again, non-epidemiologists in the room, the way a negative control works is you find another outcome variable that's confounded by the same variables as your outcome of interest, but it's not feasibly related to your main exposure, in this case, model of care. So this means that if you identify any relationship between model of care and your negative control, it can only be due to confounding. The advantage of that is that you can show how much residual or unmeasured confounding there is. So, for example, if you found an association between your model of care, model of maternity care, and your negative control outcome, this means that there's residual confounding. So our negative control outcome was small for gestational age, which shares the same confounding structures as the covariates that we included in our models, and is also related to risk of our outcomes. But there's no conceivable mechanism through which small for gestational age is related to the model of maternity care when you take out the relationship between these characteristics. So if we'd found that model of maternity care was related to risk of small for gestational age after adjusting for these characteristics, that would be suggestive that residual confounding had occurred. So looking at our results in relation to confounding, firstly, the midwife-led group were younger, they were more often of non-European ethnicity, and they were poorer, more often overweight and smokers, and booked later in pregnancy. And the medical-led group were associated with being older and had first-time mothers and booked with their LMC earlier in pregnancy. It's important to point out that the risk factors were associated with adverse outcomes in expected ways. So this is supportive that our covariate data was robust. And the strongest associations we saw were between ethnicity and small fetal gestational age and smoking and small fetal gestational age. And this is important because in terms of the negative control outcome. So in general, associations were stronger for small fetal gestational age than either the morbidity or mortality outcomes. So because the confounders are more strongly associated with the SGA outcome than the morbidity and mortality outcomes, then it follows that we should find stronger associations between the model of care and small fetal gestational age than either the morbidity or mortality outcomes, if in fact those associations were due to confounding. So I hope everyone followed that. We can answer questions about it later. It's pretty heavy epidemiology. So moving on to our results. The midwife-led group was our reference group, which means that any odds ratio below 1 means there are decreased odds for this outcome for the medically led group. Any odds ratio above is indicative of increased odds amongst medically led care. So our mortality outcomes, what we saw was a reduction in odds of all of the mortality outcomes for medically led births. Confidence intervals for these outcomes were wide and included 1, so were not statistically significant, and that's reflective of the fact that thankfully mortality is a rare outcome in New Zealand still. Important to note that the association mortality-wise was greater for neonatal mortality, which makes sense as this is most closely related to events that can occur around delivery, stillbirth. There's still many idiopathic and causes of stillbirth that have limited potential to be impacted on dependent on care model. So looking at the morbidity outcomes in our study, again, we found a reduction in odds of all of our morbidity outcomes, low APGAR, birth-related asphyxia, neonatal encephalopathy. The difference in magnitude of findings in these results was between 38 and 55% lower odds for medically led births. And our small fetal gestational age, our negative control outcome, odds ratio was 1 after adjusting for confounders, making the argument of residual confounding a difficult one. So what does this mean in terms of absolute numbers? So you can read through the slide, but essentially with a birth rate of around 60,000, what we're looking at is approximately 290 cases per year of low APGAR score and 203 cases per year of the combined morbidity outcome. And all of these outcomes are associated with pretty serious effects on the baby and have risk of mortality and long-term brain injury. So key points when considering our results. Firstly, all of our results were consistent in their magnitude and the direction of the finding. No statistical significance does not mean that there's no difference. It's really important to look at the direction of the findings. So mortality and morbidity outcomes were all in the same direction, and that was a protective effect for medically led births. And again, the small fetal gestational age, there was no difference, making confounding a difficult argument. So the findings were concerning. As researchers, we were aware of the potential to disrupt public confidence in our maternity system. Because of this, we were very careful in all of our media to show support for midwife-led care and to really point out the benefits of midwife-led care. So just a few quotes there. As a practicing midwife, I saw firsthand the many benefits of our midwife-led continuity of care model. And this is true, you know, I came from a midwifery background. I loved being a midwife. I, you know, saw how the benefits of that relationship for mums that I looked after, and I'm a huge supporter of midwife-led care. So that's something that we really wanted to make sure came out in all of our media communications, and avoid any kind of alarmist approach. I don't think I'll play that clip because we might run out of time. So I'm just going to hand over to my colleague, Professor Sarfati, who's going to go over a bit of the process.
Right. Thank you so much, Ellie. So just going back to when we first got the results of our study, we immediately knew that these were likely to be of major interest to the sector and were quite likely to cause a lot of controversy. So we wanted to make sure we were being very, very careful. We had been very careful with the design of our study already. And what we did at this point is we got an independent person to completely reanalyze the study to make sure that there were no analytic errors, and there weren't. And then we sent our study to 6 senior methodological experts. So these were the people that we knew would be able to pull apart the study if there were methodological flaws that explained the results. So you can see the names there. Tony Blakely is a leading methodologist in New Zealand, for example. John Lynch is an editor of the International Journal of Epidemiology, which is the leading journal of epidemiology in the world. Very strong methodologist, very good at assessing potential methodological flaws. The conclusions of all of these experts was that it was difficult to make the case that any methodological flaw could explain the findings. All considered that the results were very concerning, but of course none concluded that the study was perfect, because there is no such thing as a perfect study. So what did we do prior to publication? A year before we published the results, we got the results, we knew that they were concerning, we started meeting with the Ministry of Health. And the purpose of these meetings were twofold. The main one was because what we were thinking is if we release these findings, they're going to cause a lot of alarm. And we thought it was going to be a lot better if we can release these findings and say, this is what we found, but the Ministry of Health is already doing A, B, and C. And so you've got a much more reassuring message. And the ministry was really on board with that idea. We also wanted to share our messaging and make sure that they understood the study so that we were all on the same page. We met with the College of Midwives with the same agenda several months before publication. So we shared our research, we shared our media messages, and their response at that time was that they were very grateful for that engagement. They acknowledged that we were under absolutely no requirement to make that effort. They acknowledged the importance and the validity of the study findings, and they indicated a commitment to take action. So, for example, here is an email that was sent to us from one of the senior ministry people who said, I appreciate the ethical and collegial way in which you have approached this issue. I think with careful handling, it could be a catalyst for ongoing quality improvement in the maternity sector. So at this point, things were looking good. And then the findings came out, and they were all over the media. You may have heard something about these yourselves. They were leading news. There were all sorts of different media stories taking all sorts of different angles. There was an in-depth article in The Listener. The article itself was exceptionally well written, an excellent article. Unfortunately, the cover of The Listener was completely unnecessarily inflammatory and caused a lot of upset, which was really unfortunate because that's exactly what we wanted to avoid. There was a lot of editorialising about the issue, so in all sorts of places. We were getting some informal feedback on the study. For example, this writer said, this is frankly misleading, although does make for good headlines. Later says, the article is written suggesting that the women with adverse outcomes were purely looked after by midwives, which is categorically not the case. So I'm not sure if this person actually read the study. But also said, slightly amusingly, that they find the choice of publication interesting. Most well-conducted studies would be published in RANZCOG, which is the Royal Australian New Zealand College of ONG, or the Journal of Midwifery, not online. PLOS Medicine is one of the 10 leading medical journals in the world. Very, very difficult to get into, and far more difficult to get into than either of those two journals. But the final comment was perhaps the most concerning. Don't lose faith in your midwife. They're good people. As if researching this area and finding concerns with the system suggests that in some way that means that midwives are not good people. And then we started seeing a bit of a shift in the ministry approach. So there's some quotes from stuff that came out of the media, out of the ministry a week or so after publication, So they said the Ministry of Health has referred the study to the National Maternity Monitoring Group. Now this is an important group, it's largely clinical group, so it's not a methods group, and they're really important in terms of developing policy to respond to this kind of things. Anyway, they were going to refer the study to this group for advice on whether further research needs to be undertaken to help us better understand whether the findings reflect something about the way the study was done. So already the focus is shifting to the study rather than the system. Later in the same article, issues that needed further exploration included looking at what other care was provided to women in the midwifery-led group, so it's sort of a misunderstanding that the midwifery-led group means that it should only be midwives, and looking at differences between the types of women being compared in the study. So in other words, concerns about confounding. So they were starting to look at methodological issues. And later in the same article, the study has been criticised by the College of Midwives, who say the findings simply show a rich-poor divide. Dismissed. We countered those criticisms publicly, so they also made it to the media. But we also had criticisms made in the formal literature, particularly this article. This was published in this journal, which is the Journal of the Australian College of Midwives. It is written by a senior midwife who criticised the research, as you can tell by the title. It's an editorial, so this is not a peer-reviewed article, it's her views on the study. But then this article was subsequently cited by the ministry as sort of providing proof that the study was in fact flawed. So what were the main criticisms? I'm going to whip through these reasonably quickly, and I apologise for the non-epidemiologists in the audience. I won't explain them all in detail because that's a whole epidemiological lecture which you don't want. But the first one was that there was misclassification of the exposure. In other words, the midwife group included care that wasn't just midwives, and the doctor group included care that wasn't just doctors. This was completely deliberate on our part. We were interested in midwife-led care. So the midwife-led care does not mean that only midwives are involved in the care of that woman. So this was exactly what we wanted to look like, and it was entirely consistent with the approach the randomised controlled trials had used. So we didn't accept that criticism in the first place. But the other epidemiological thing to note about that is that if there was misclassification of those two groups, the only conclusion that you can draw is that we underestimated the associations, that actually the problems were bigger than we measured. So I suspect the people that made that criticism didn't understand that the impact of that is that the problem is actually worse than what we've measured. Confounding, so that there were differences between these two groups. This was often thrown at us as if we hadn't thought about this. In fact, we had done a huge amount of work to look at that issue, and as I think has been made clear, it's difficult to explain these findings away based on that criticism. That we should have supplied absolute numbers, so the number of babies affected in our media releases, that it was alarmist not to do that. We thought about that really carefully, and we actually chose not to do that because we thought the numbers would be used in alarmist headlines. We could see the headlines, 200 babies every year, that kind of headline. We didn't want that kind of headline. So that was a judgment we made, but then we were criticised for it. So that's a judgment call. There were comments that there were no differences in mortality between the two groups, and therefore there's no problem here. And I think we've addressed that. I think Ellie's already talked about that, so I'll leave that there. This study was observational, therefore it can't inform causality. In other words, this was not a randomised controlled trial, and informing causality means that you can't say that there was potentially a link between the model of care and the adverse outcomes because it was an observational study. This criticism is repeated so often that many people believe it is true. Can I just say it is categorically, absolutely untrue. The process of causal inference is complex and it is not dependent on any particular study type. That's a whole lecture which I can give another time. There's a huge literature on that which I'm very happy to share with anyone who's interested. But suffice to say, if it was true, we would not yet know that smoking causes lung cancer. We were criticised for not including all possible outcomes, which is again a very odd criticism because no study includes all possible outcomes. And also that the study was retrospective, so therefore innately poor quality. Again, this shows a bit of epidemiological confusion. In the past, studies tended to be categorised as prospective and retrospective. That's kind of fallen out of favour because it causes confusion, as we saw here. And again, I'm really only talking to the people who understand what those terms mean, but in this context, the data that we used on exposure were all recorded prior to the outcomes. the data were actually recorded prospectively. If you did a prospective study at the same time using the same data, you would get exactly the same results. I'm aware of time. I'm going to whip through other recent findings that were at about the same time to see if we were really outliers in our findings. The first one was a study looking at neonatal encephalopathy. They looked at the 83 cases that occurred in that time period. They found that nearly all had contributory factors, and 3/4 of those were personnel factors, which were the knowledge and the skills of staff were lacking. There was a failure to offer or follow recommended best practice, and a lack of recognition of the complexity or the seriousness of the condition by the caregiver. But that study gave no information about the caregiver, what training they had, or anything else that could, allow us to take action on that. A study on perinatal mortality also found that half of the cases had contributory factors, just under half were avoidable, and there was suboptimal care in a third. And then there were these two studies that looked at early career researchers. Just in summary, both of these studies found that midwives in their first year of practice had worse outcomes than more experienced midwives. Both were consistent on that point. The first one did not have access to other pregnancy risk data because it was an earlier study. The data wasn't included at that time. The subsequent study did. And what they found was that the effect of that experience effect was less once you adjusted for other risk factors. What they found was that new graduate midwives were dealing with a higher risk group of pregnancies. They had more women who had diabetes, more that had hypertension, more that were had high BMIs, more than there were smokers. So basically, the first study identified a problem, and the second study found a systems issue that needed to be addressed. Although the way that those studies have been reported in the media and the way that they've been discussed by the Ministry of Health and College of Midwives would suggest something quite different, that they were not in agreement. So what happened after publication of our study? The focus shifted from the research and the system to publicly discredit both the research and the researchers. We were accused of bad science, being ethically questionable, in it to scaremonger, and being anti-midwife. And I'm going to use this article, which was published recently in Stuff. It was put together by an investigative reporter, Michelle Duff, who obtained documents under the Official Information Act, and she concluded that they showed attempts to spin the results of the study and avoid the spotlight on the safety of the system. And a few examples that she used. I was sent notes immediately prior to publication from the College of Midwives National Committee meeting. And those notes, which had been spread round the College of Midwives quite widely at that time, said that once again, flawed research that based information on wrong assumptions, watch for publications, College and Ministry of Health prepared to address the concerning issues of this poor research. There were two problems with that. A, the research was being completely dismissed, and B, there was a breach of confidentiality. It was confidential at that stage. In an email to the CEO of the College of Midwives, a senior ministry official said, "We are likely to support the system New Zealand women have. My idea would be to raise questions about the study." I had been invited to go to an upcoming meeting of the National Maternity Monitoring Group, which is a group that I spoke about before. I felt that was very important because I thought it was very important that they understood the methods that we used, particularly because they were a largely clinical group, and they understood both the strengths and the weaknesses of the study. But the day after the story broke, I was emailed to say that I was no longer invited, that the agenda was full. I was really concerned about that. And the ministry officials took the very unusual step of meeting with Peter Crampton, who, as he said at the time, was a pro-vice-chancellor. So in effect, my boss's boss. And they were trying to make the case to him that the study was flawed. He himself was a researcher, and he strongly disagreed with that assessment, and he backed the research. And in a quote to the journalist in the Stuff article, he said, "The ministry's response implied a problematising of the research in a way I found very unusual and disquieting. They viewed the results as highly problematic, and my general sense was that there was considerable effort to explain them away." And a couple of other emails, an email from the CEO of the College of Midwives, she accused us of scaremongering and bias. She said that the study had a lack of credible analysis and discussion. And in the weeks after the publication, the senior ministry official emailing another person in the ministry said that the study and its data were unreliable, and she had no clue how the researchers had obtained their results, which was a little disturbing because we had spent quite a lot of time trying to explain that. And then finally, another senior ministry official sent a reassuring email to the CEO of the College of Midwives saying the study contained major methodological flaws and would soon be consigned to the back pages. Again, I want to remind you that we had the top methodologists review this paper. So it's a really big call for the Ministry of Health to be dismissing it in this way. So what happened next? I'm going to hand back to Ellie.
Yeah, so what happened after all of this attention? The National Maternity Monitoring Group met without Diana and came up with 4 recommendations. So you can see them there. They did to develop a multi-component coordinated maternity research program, to request the ACC to undertake further prospective research relating to the context of maternity care as it relates to neonatal encephalopathy, that data owners ensure that ethical data processes are followed, and to consider how messages are communicated. And we agree with the first 2 recommendations, and they're similar to those that we made in the discussion of our paper, and that we really need more detailed analyses around this area. The last 2 recommendations were more difficult to swallow, as it felt like a bit of a dig at our processes, considering how careful we've been to address both of those things. So what's happened between then and now, 2016 and 2019? Nothing really seems to have changed, and there's been no public awareness of any mechanisms that are underway for addressing the recommendations of the National Maternal Monitoring Group. A media report last week said that the Ministry of Health were unable to provide any evidence of processes that address these recommendations. So maternity policies remained unchanged, and it's business as usual, essentially. As Di touched on, a staff journalist, Michelle Duff, revealed a level of collusion between the Ministry of Health and the New Zealand College of Midwives and how the findings of our research was managed. A response from this article was that Julianne Genter, the Minister of Women's Affairs and Associate Minister of Health, said that she'd be questioning the Director General of Health over the Ministry's treatment of both our study and of the Beverly Lawton study. So where to next? We made a number of recommendations in our study, which we still stand by, and they've been included in our study since 2016, so I won't go through them all. But essentially, there needs to be, there's a clear need for more detailed analyses around the reasons for the apparent excess and adverse outcomes for midwife-led births. And there's a number of mechanisms we can go through to do that, but that's, again, probably another lecture. But key considerations when approaching this work: it needs to be done in good faith with an open mind. There's so much history in politics and maternity. It's important to remember that we're all aiming for the same thing, and that's the safest and best possible outcomes for mothers and babies. Importantly, when approaching this kind of work, we need to include a range of people with high-level skills in research and data. Assessing the quality of a system requires such high-level expertise in research methodology, which is quite separate from stakeholder expertise, midwife or medical expertise. Independent researchers are important because key stakeholders can hold perspectives, particular perspectives, which can impact on the planning and interpretation of research and lead to bias. Finally, it's important to consider in general how evidence is incorporated into policy. We've got a maternity system that's never been based on evidence. We've seen through our process that even after, to some extent, addressing the paucity of evidence that relates to our system, there's still yet to be any translation or movement policy-wise around this. So I'll leave you with this slide and quote that you can read through. But essentially, all parts of the health system are, or at least they should be, under frequent scrutiny, with the aim of driving the best possible outcomes for the consumers of health services. Our research has contributed to the understanding of the performance of our system, and it's highlighted that there are areas that need improving. So with the intention that we're all working towards the best possible system for mothers and babies, we need to address the concerning findings in our research. So with that, thank you, and thank you all for coming, and thank you for the attention, and I'll hand over.
Thank you very much. Is that on? Yeah. Thank you very much to Ellie and to Di. We do have some time for questions, and I'll be looking to James as well if there are questions coming in from our web attendees. So I'll open it to the floor at this stage, and please just put your hand up. And if you have a question, could you just identify yourself just with the name and your interest? Thank you. And while we're waiting, we'll turn to James.
Okay, this is a question from Bronwyn Drysdale. So there are a few questions here. Some of them were, I think, addressed during the presentation. So this question is asking about whether there were elements of the research that looked on systems and equity in terms of access. I'll just read here from the question. So this is a vital research aspect, as the PMMRC says that women from lower socioeconomic areas and Indigenous Māori, Pacifica and Indian women have less access, potentially longer wait times in terms of obstetrically indicated care, and poorer outcomes in relation to maternal and infant morbidity and mortality.
Yeah.
Thank you very much for that question. I mean, that's a very good point, and I think making sure there is good access to care and quality care for all is really important. We weren't looking specifically at inequalities in this research, and those differences would have been taken care of in the methods of our study. And that's really part of what we mean by there needs to be more in-depth research into the system, what's working well, and there will be many things working really well, and what's not working so well, and for whom it's not working well. So that absolutely, looking at whether the system is working well or not is critical follow-up.
Yeah, but we definitely did recognise that there were differences and adverse outcomes dependent on demographic factors. And as we know, we controlled really carefully for those differences in our methods, and that included rurality. We did some sensitivity analysis around rurality and access to services.
Question in the middle.
Hi, my name is Ellie. I'm also a PhD student in obstetrics and gynecology up at University of Auckland. My question for you about the confounding is around the use of SGA. To check your confounding process, and I'm just what's bothering me about that is that there are many more obese and overweight women in the midwife group, and we know that obesity and overweight is associated with poor outcomes from pregnancy and in neonates. And we also know that women who are heavier are less likely to have small babies unless you are adjusting for that in your definition of SGA. So I just want to ask why you chose to use the definition of SGA that you used and didn't adjust it for the mother's size and parity and so on.
Thank you for the question. We actually did do quite a lot of sensitivity analyses around the SGA as well, and we did look at the impact of BMI. What you're describing is that BMI is a confounder, so that's sort of the point of having SGA. So that it's part of that confounding structure. The difference with BMI, as you quite rightly point out, is it works in the opposite direction to the other confounders. So you tend to have bigger babies rather than smaller babies. So we tried the SGA with and without that, and we tried it within groups of women that all had normal BMIs, and we found the same thing.
And that might be the subject of a more detailed offline discussion as well. And there was a question here, and then there's one up at a microphone up at the back. Yes, okay.
Oh, thank you very much. I'm Brendan Bacon, I'm a paediatric surgeon. I've got a big interest in under 5 mortality. In 2013 on BBC in London, the figures were released that essentially placed New Zealand at 34th in the OECD country listings based on under 5 mortality, looking at 2011 figures. 2013.5 figures placed us at 37th. And while raw data isn't palatable for some people, we can get very accurate raw data as to what that means for kids. It's about 140 deaths a year from each from the 65,000 kids that are born roughly, there are 140 each year who are going to pass away before they reach 5 who wouldn't have if they're born in Australia. So there's massive variance occurring for kids now, placing us 37th. Can I just ask, in relation to the perinatal component of that, which you were alluding may not be significant, do you have any data that tracks kids out of the perinatal period, but maybe to the infant mortality period in the first year that also supports your situation? And the second question is, and this is very important, the New Zealand Ministry of Health surely must have the mandate for actually leading this research and leading these methodologies and driving these assessments, but it appears it's completely absent.
Yeah, I mean, to address your second comment first, I agree. The first question, did we look at mortalities within the first year of life? We didn't. We only included mortality up to 28 days, and the reason for that was because deaths that occur in that period are most likely to be related to things that have happened around delivery. Deaths that occur following that, there's a whole bunch of different things that can be introduced, and so that would have confounded our findings. So we didn't include that in our analyses.
Thank you. Now I'm just going to turn to James. Do we have any burning questions coming in online? And then we're probably going to run out of time after that.
There are a couple of questions here which are probably technically for the Ministry of Health and other bodies to answer, so I won't ask those questions here. There is one question about, I guess, what would have happened if women who'd had elective caesarean sections been removed from the analysis, given that one of the outcomes of interest is intrapartum hypoxia.
Yeah, so the mode of delivery, that was another thing that came up in some of the criticisms. We didn't control for mode of delivery because we considered that to be a mediator in the relationship. So decisions around providing care and mode of delivery, so that could involve induction or routine caesarean section, those decisions do have a relationship to risk of outcome, but that's part of the care process. So we didn't want to adjust for that because that would take away the fact that there was a relationship between the model of care and the adverse outcome. And
could I add to that? We were looking at systems. So one of the issues that might be very important is that if you're an obstetrician looking after a woman and she gets into some sort of trouble, you can go straight to Caesar, and that can happen very quickly. But if you're a midwife and that happens, there's a delay. There's an inevitable delay before you can get to an obstetrician and for that to happen. So that would be a systems issue, and to look to see whether or not those delays were reasonable or not. So that would be a mechanism through which we might get these sorts of findings, and that's exactly the sort of research that we need to be doing to understand what the kind of mechanisms might be.
I think we can address them.
Thank you. So there's still hands going up. We are out of time now, so probably I will draw this to a close now, and I apologise for that. But please feel free to come down and join Ellie and Di for some discussion and questions afterwards. So I would ask you to join with me and thank again our presenters today.